So that's it. I think we've got just the rest of the time here for any questions that we might have either online or in the room, and John's going to moderate this.
Thanks very much, Heather. And for the joint events, there are any events that are freely available and targeted OHTs that we're profiling sites. So again, they don't have to be RISE specific. So if you become aware of an event targeting OHTs that's free, we're happy to make it a site. Any online questions that have come in yet? So, and just for folks in the room, we'll bounce back and forth. If you have questions, we'll get to you shortly.
So the first question is, based on the attributable example of persons living in Hamilton but rostered to a physician in Toronto, how will OHTs mature? Will the example patient receive home care from the Toronto OHT, and where will hospice care be offered? It doesn't seem like a population approach is being used.
Well, I think it is very much a population approach. It's just that I think you can go down different paths in thinking about a population, and I think many of us, and I'll include myself in this, initially read the guidance document and saw geographic and thought that that meant like our usual sense of geography. So in this case, the boundaries of Hamilton. But over time, I think the ministry has realized that two things. One is they don't want to disrupt how patients currently receive care. So if I live in Hamilton and I commute into Toronto and it's better for me to be rostered with a primary care doc there, why should someone tell me I can't do that? And similarly, if a primary care physician always refers patients for hospital admission to a particular hospital, why not accept that as a naturally occurring referral pattern? And that then becomes part of how we think of it. So it's very much still a population-based approach. It's just a population that is in keeping with how people currently access care or are referred to. And then those people will be accountable for, the team will become accountable for that care, minus the highly specialized services. And where that dividing line is, what is considered highly specialized hasn't been articulated. That will come. But initially, the focus is primarily the basic home and community care, the primary care, and the kind of secondary care that you would receive in a hospital, not highly specialized tertiary and quaternary. So I think that's the vision. The complication for the home and community care side is not the care delivered by community-based organizations, but the care delivered by that is labeled home care. And the reason why that is complex right now is the ministry is going through a process of trying to figure out where does home care go over time. Teams invited to full application have been invited to think through how are you going to deal with your year one priority population. And in thinking through that, you'll need to think about how do we want home care to work. And you're given an opportunity to say, well, for our priority populations, we think the best thing is these navigators or these other people that are currently part of the home care system and employed by the LHIN should actually sit in primary care practices. And the ministry is open to hearing about that. So you have the option then in a say of saying, we would like you to think about as you redesign, as you think about what the future of care is, that if this could happen, it would allow us to better deliver on our priorities for our year one. So it's still population-based. It's just an attributed population, not a geographically defined area. And all of that home and community care, primary care, specialty care is in, minus the highly specialized. And where the dividing line is, we don't know. And on the home care front, there's a wait and see element to that particular case, but the ministry is very open to hearing about how that.
And just part of the first piece of the question about how will these mature, it's possible that populations change, correct?
Absolutely, for sure. So, Rob Reed, I don't know if he's listening in now, but he's a co-lead along with Jeremy and me, and Rob has this expression of surprise and delight. Like if over time, a particular community, let's say Hamilton, surprises and delights its local population, and right now I live in Hamilton and commute into Toronto and I'm rostered in Toronto, there's a good chance I'm going to say, oh, I'm going to get rostered in Hamilton, because everything I hear is that care in Hamilton, they're doing an amazing job. So yes, these will change. And I can't recall now if the ministry is how frequently the ministry will refresh the attributed population. I have one every year in my head, but that will change. So if over time people change where they go or primary care providers change where they refer, then that attributed population will shift accordingly.
Just walking over to a person who has a question in the room.
Play by play.
Hi, I'm Curtis Kitagawa. I'm patient advisor, volunteers for about 8 different partner agencies under one of these applications. One of the things, I have a couple of things. First of all, I'm very pleased to see the new approach being introduced. The goals sound terrific. One question I have, when in the presentation this afternoon, when you're talking about the end user, you're referring to the actual agencies who are partners in an OHT application. Now, the real end users, of course, are the patients and in some cases, informal caregivers. In the current system, and I don't blame anybody for how things are done, but in the current health system, the notion of accountability to patients, except in a family practice under a family physician, is an unknown concept. Hospitals, for example, when they're confronted with complaints about discharge planning, for example, they refer things to a client and family relations department who don't really see it as their job to resolve concerns. They just need to respond. The patient ombudsman supports them in that. As long as the hospital has a process in place for hearing concerns, there's no requirement to resolve. The College of Physicians, for example, the accountability of the physician is to his college, not to the patient. Of course, indirectly it is to the patient. I'm wondering, under this Ontario Health Team's model, whether any thought has been given to what mechanisms can be put in place so that there is some form of direct accountability to the patient, modeled on what currently happens in a patient's relationship with a primary care doctor, because that's a wonderful example of where things are done typically very well. It's partly because of the therapeutic alliance, the direct contact, the frequency of consultation, and so on, but it's done particularly well. I'd like to see a situation where we don't need to give the patient ombudsman extra tools to enforce. I think the goal we want to strive for is, if we're going to be providing wraparound care for a patient, then there has to be some way for a patient to ask for appropriate help and receive appropriate help. And in that light, one of my concerns is with regard to educating patients with regard to the new system, and educating patient and family advisors on how they'll best be able to help under the new model. Because one of the things that is important in all the volunteer roles that I play is an informed consumer of services, no matter what the service is, actually helps to create efficiencies in the system and produce better outcomes. And so, on the negative side is sort of, accountability mechanisms back to the patient, and the other side is, how are we going to strengthen patient and caregiver education so that they can be an active partner in asking for the right things in the right way at the right time and the right.
So, all fantastic comments. I'll just pick up on a few things. The first is an apology if I said anything that suggested the end user wasn't the patient, the family, and the caregivers. So that is the priority. So absolutely. Second thing is that the quadruple aim specifically zeroes in on patient experiences and health outcomes and tries to reorient people to, at the end of the day, you should be accountable for how people feel treated by the system in the most holistic sense of that. And over time, I think the ministry will be guiding us to a set of patient-reported experience measures that systematically capture that. Right now, we have complaints processes that are about problems happening but aren't necessarily giving a systematic and transparent picture of the full diversity of experiences. So that's another way that they're going to deal with it. Third, building block 3, which is patient partnership and community engagement, is really focused on this. It's saying we have to change. Patient partners needs to be involved in governance. They need to be involved in leadership. They need to be involved in co-design. They need to be involved in all aspects of this. And part of what falls under that are domains like health literacy, being able to understand how to make sense of the system and being supported with navigators to understand how to move the system. So I think you'll see in a lot of this stuff that the principles that you've been articulating are reflected very nicely in the model. And the expectation is in the application form and all subsequent steps that patient partners have to be there to help to design this. So I keep hearing from folks who sometimes suggest almost like they're frustrated that every last detail has been articulated. But this is unbelievably exciting because we get to design it in ways that make sense. And the government has said patient partners need to be there at the table to co-design it. So I'd like to think that everything that you've articulated has the potential to really take off with this model. Carrie, any questions or comments online? No? Oh, it's a big but quiet group online. Oh, Heather, everybody's on the other end of the room. And this is Frank's second session, so he only gets one brief question. I just heard great things about Kemptville Hospital, I should say, by someone who gave me a lift to this meeting today. I'll introduce him to you later.
Oh, thank you very much.
I don't want to break patient confidentiality.
Okay, thank you, John. First of all, quick question. Comment is thanks to the ministry for supporting the development of RISE. This is a tremendous resource. We've had limited exposure to it, but we anticipate tremendous use of the resources as we move our OHT forward. My question is relative to, I believe it was on slide 93, John, about the in-reach services, and this is a question coming from some of our primary care providers. Great idea, increasing the scope. They're getting their head around the logistics, how we're going to make that happen in their practices. But the question they have specifically to the in-reach would be, is the ministry thinking through how the fee codes are going to change and how the whole sort of regulation around negation, punitive things, aspects of that? Because, that's going to butt up against the current model.
Yeah. So my understanding is yes, and the more precise you can be about what the concerns are. So one is, the old one visit, one concern, but then also certain rostering models have provisions that penalize doctors for doing certain types of things. So my sense is that's open for discussion, and then that will be the basis for, ministry's ongoing interactions with the Ontario Medical Association to try and figure out what does a refreshed model look like in terms of physician payment. So absolutely, and the more precise we can be about what's not working now, but will need to work in order to enable in-reach and other services, you should send it in to folks. Ministry?
This presentation, so I got my following question is this. So we have put forward a proposal, and it's really in regards to acquired brain injury services. And my team together we're quite adept at collaborating with one another. One of the things that lacks, though, is, and I'm going to use this, is that, because of the region that we're looking at as Champlain, is we don't really have a great reach in the Francophone population. So is there any way, and I'm going to use this term, that my OHT interacts with another OHT, and how will that come together?
Yeah, so I think, again, the great thing is you have the flexibility to do things in ways that make sense. So I guess my initial reaction, though, is just to step back and say, might that not be too specialized a service for OHTs? So I think you need to think about, is it realistic to think about a group having enough of a population to make it viable to provide that full suite of home care, primary care, and then acute or specialty care? Because to be a team, the ministry has not specified a minimum number, but it's clear that in order to have stable metrics, you're going to have a pretty big population. Otherwise, just one or two patients would throw off your performance metrics, and then you might end up in trouble in the long run as a result. And then in terms of capacity, running a team is very complex. I mean, we're only now at the initial days of talking about what could be done, but many teams are just finding it difficult to staff this on top of keeping organizations running. So if you're a small group serving a small population, it might be very difficult to have enough staff to perform all of the functions necessary for a team to be successful. So step one is just stand back and just think about where are you on that spectrum between the intention of the model, which is that full spectrum up to but not necessarily including highly specialized. Step two would be to look at the map. If you're a team in development and you're going to be getting the map in the coming weeks, are you a team in development? No, in discovery? Yeah. So the difficulty will be there's no, as far as I know, not a current plan to share maps with teams in discovery, but the hope would be at some point this will become very transparent and everyone will be able to. But in the short run, in your community, ask if the teams that have been invited to full application, the teams in development are willing to share your map, their maps. That will immediately tell you how do you fit into the naturally occurring utilization and referral networks. Because if those populations have already kind of been allocated, it's hard then for you to come in, especially with a specialized service. So then that brings me to your final question, which is then you need to be knocking on the door of the existing teams and saying, how do we partner? And I come back to, I think I've used the term bandwidth earlier, where the teams invited to full application, their heads are down, they have no bandwidth for anything other than what will get us to October 9th in a successful application. Those ones you might want to just say to them, do any of your priority populations touch on acquired brain injury, in which case we'd love to be there to talk to you about how do we do a handoff to groups like you. And then if otherwise, I would wait till after the 9th and then talk about the future. But for the teams in development, within a few weeks, they'll have their maps, and then you can start to approach those groups. So just as with RISE, we're trying to kind of titrate what we do depending on where people are and their ability to absorb information and what they need, I encourage you to do the same. But it sounds to me like these teams in your area are the ones you should be speaking to when they have the bandwidth to be talking. And if they prioritize your population, they're going to be knocking on your door if you don't knock on their door. Does that make sense? Great.
Two questions for you. The first one deal with the attribution model and trying to understand those people that are in the full implementation mode right now. So they're going to see the so-called networks, I guess, if you will. Yeah. I'd make an observation, though, and it's been pointed out to me by several people. The application that we submitted for the OHT clearly said, please define your geography. It was very, very clear in there. And so I think many of us just went and said, okay, you want a geography? Here's the names of the streets and all that type of thing. And I think it had to do because there was quite a bit of a focus on saying, please tell us how many people are in that population as well. And as you know, over the period of time, there was lots of discussion. Should it be 300,000 people, 50,000 or whatever it was? So I'd appreciate that. But I am somewhat interested that it's great the ministry now has a, if you will, a map of the entire province. And some of them have said to me it would be great if we'd shared that first. And I think many people would agree. I'm just wondering how that is going to be rolled out when you've got different people at different levels of implementation right now, and how we can mitigate that potential risk because some players may or may not be part of other groups, et cetera. And the second question I had, one of our comments was on digital health, saying did not believe we had a robust plan for digital health. Do you see any more resources? I have not had a chance yet to take a look at the playbook, but if I receive that comment on that, do you have a sense that RISE would give more information on the digital health platform, what's required, or is it going to be just strictly the digital health playbook?
Yeah, so it's a great comment. So let me start with the second one. The digital health playbook has just become available, so we haven't fully wrapped our heads around all of it, but it seems like an incredibly rich resource, and at this point, it's not obvious to us that we could add value on top of that. What it does is help you understand the province's aspirations for digital health, taking us from where we are to where we need to be as a province, and helping people understand the importance of having solutions that make sense locally and build on local assets, like electronic medical records that have already been invested in, but at the same time needing to move us as a population to a system where you can communicate across teams. Second thing it does is it lays out in 4 policy documents the thinking in areas about what needs to be done and how. That gives a lot of prescriptive guidance to how to approach this. And the third thing it does is it lays out a catalog of assets that are supported by the ministry or its digital health delivery partners, and signals a willingness on the part of those partners to work with you to try to move forward on digital health. So I think that that's probably going to meet most teams' needs, but if somewhere along the line you and others say, we would really appreciate X or we'd really appreciate Y, we would then communicate with the digital health folks and ask, is this an appropriate role for RISE? And if they said yes, then we would quickly respond. On your first point, point taken, I think that the reality is that, again, I come back to that point that this is an exciting opportunity because we're all co-designing it as we go, and I think that the ministry's thinking continues to evolve as it hears from other people. And I think what happened was they went in thinking geography like the rest of us, and over time the many challenges associated with geography emerged, not the least of which it probably would involve telling patients, you can no longer do this, or providers, you can no longer do this, and you can understand why that would be very sensitive. So they were able to then identify this attribution model that seemed to address many of the challenges. But I recognize that if you planned around a certain understanding of geography, as a number of teams did, and now you have this new understanding, it requires you to adjust. And then in terms of timing, again, the ministry, my sense is from the outside, they're trying to do things as quickly as they can on the most time-sensitive issues. The biggest burning concern is the October 9th deadline for teams invited to full application. That's why they got their maps last week and this week. The next biggest priority is teams in development, and my understanding in the first half of September, they'll get their maps and the debrief. So they're trying to get this stuff out as quickly as possible, and then fingers crossed that sooner than later, we get the full map, so then the teams in discovery have a sense of, is there unoccupied space here, or whose door do I need to be knocking on in order to start the conversation? So I think they're trying to kind of listen to people and make adjustments as they go, and sometimes that means it might feel like we took 5 steps forward and a bit of a step back, but the net direction I think is definitely forward. And I think the maps are now going to be key. In the last week, I've just realized how so much centers on our understanding of those maps. So I'm one of many voices saying, let's get them out as quickly as we can because they're essential to every team's next step conversations.
Hi. I just wanted to speak from the primary care perspective, which is a fairly new world for me over the last year and a half.
Okay.
But what I do understand is that primary care physicians have very limited ability to engage in these kinds of discussions.
Right.
I mean, they're busy seeing patients,
Absolutely.
right? So, daily we have like noon hour, lunch and learns, webinars. I mean, they basically give up their lunches almost every single day just to facilitate some of those discussions.
Okay.
So I think as we move ahead, it's going to be difficult because primary care, even family health teams, we have very limited resources as well.
Yes.
From an administrative perspective.
Yep.
So we've got to figure out ways to incentivize that involvement and make it a positive one because they're all committed to care of their patients. But in order to get the results that we want, we've got to get the buy-in and we've got to figure out a way to make that work. So, and I don't think it's going to be OHT by OHT. Actually, I think we have to come together as OHTs and figure that out together and then have those discussions sort of on a provincial basis. So just a note that, I think that whole primary care sphere is absolutely critical to our success, but we're not structured right now in a way to easily make that work. So.
All points well taken, and I very much agree with your idea of, we need to be sharing across teams what are some of the approaches that they think make sense, and then talking about how do we scale this up to the provincial level and really work on the stuff that makes sense. And it also comes back to, for many folks, it's going to come down to a payment issue, and we need to have those conversations about what does that look like. But at each step of the way, we're never going to solve all the problems into the future. We're going to have to incrementally deal with the next most pressing issue, but this is going to be front and center in many of those conversations, so we need to lift it up forward. And we can do that through the community of practice, and then share those insights when we've got some things that we think could be scalable, share them with the ministry in the hopes that then they can move them forward.
Thank you again. I've got another question because, again, my team we're not all part of the Ministry of Health. So the self-assessment that we did, and if we're all part of the Ministry of Health, it was pretty simple for us to come together and work collaboratively because we're used to doing that. Yep. Well, we started to think outside the box of what are some of the underserviced populations that we have that we're not reaching. And certainly one of them is incarcerated individuals. So we have to create, if you wish, partnerships with other ministries within Ontario. But if we want to go even further, we also know that there's the Veterans Affairs, because veterans, da-da-da-da-da. So, and it is an opportunity to think outside the box and to create a better system and a better service for all of them. So what kind of words of encouragement that can you provide us with, or tools or anything of that nature? And thank you very much.
So, right now the team model is meant to focus primarily on the healthcare partners that are funded by the Ministry of Health. And right now the plan is the eventual funding envelope that would come would be that Ministry of Health. But we have spoken to so many teams that have partners around the table that are much broader than that. So if you want to be inspired, listen to the recording from Monday's webinar where Paul Johnson, who's the head of Healthy and Safe Communities, I think it's called, for the City of Hamilton, talks about why they have come to the table. So their funding is separate from the Ministry of Health, and they cover housing and Ontario Works and a whole set of other things. And he's at the table because the same people that are going into emerge, the same people that are falling through the cracks in primary care, the same people that the healthcare system feels it isn't doing justice by, they are seeing on a regular basis in their housing, in their supportive housing, in their services programs. And they feel like we will all get much farther faster if they're at the table. So he's sitting there as a full partner, even though there is no current plan to integrate that budget envelope. But he just thinks at the end of the day, these are our same clients. They don't need to care whether the funding comes from the Ministry of Health or some other ministry or the city. They just need optimal care. And if we are serious about improving the health of Ontarians, we need to have those partners at the table. So if your work intersects with prisons at both levels, provincial and federal, see if you can get them to the table. And at the end of the day, it has to be because it's the right thing for the client. It can't only be about whether it's affected by the funding. So I'd encourage you to follow in that path. And again, if you want inspiration, 5 minutes from Paul in that recording is worth its weight in gold.
Thanks. A completely different question from what I had before and from the last one. Currently, there's Healthlinks, which is, making its way along. But one of the challenges, and I assist with a couple of the Healthlinks here in town, one of the challenges is who's going to play the case manager role. And if it's not actually assigned to a person, there isn't an ability for a physician to bill, for a consult that involves a Healthlinks issue. But family docs don't have a lot of time, and in the future with the Ontario Health teams, might it be something that could be considered that a family doc could hand off responsibility for case management or quarterbacking the file or whatever you want to call it to a social worker who could bill by proxy? I don't know how that would work. I know that social workers haven't been able to bill OHIP in the past, but it seems to me that might be a kind of workaround that would allow the family doc to do what they need to do and for that patient still to have that case management service.
Yeah, so I didn't think you were going to go down the physician fee schedule route, but obviously if there are things that you think could be accommodated within that particular mechanism, then same as my comment to Frank is share it, because the ministry wants to know what the full portfolio of solutions could be, and then it needs to very pragmatically work through which can it prioritize and deliver on. But where I thought you were going to go was, this is an opportunity to re-envision home care, and that includes where do those case coordinators, case managers, and others sit. So Appendix A is very much about, if you have the bandwidth to give us input, it's kind of a voluntary part of the application. Tell us what you think home care should look like. But for your year one priority populations, for your teams, you need to think about how are you going to interact with home care. And as part of that, ideally, where do these people best sit? So as opposed to sitting in a separate office, maybe they sit in a primary care physician's office and they're right there and the handoff just happens and it's part of the already existing home care budgetary envelope. So think through, using year one priority populations as an example, what would be an optimal configuration, and then encourage people to put that in Appendix A so the ministry thinks about it when it's noodling through how is home care going to be configured in the future. So it's a great opportunity to get much tighter connections to those types of assets. Harry, any other question? No, my goodness, there's a lot of people online and there's very quiet. All right. So we just have 5 minutes left, so let me do last call for the people in the room and then last call for the folks that are on the line. So folks in the room, any final burning questions before we wrap up? Okay, and last call for those who are online. Any final questions? No questions? All right. So let's wrap up. So thank you very much, everybody, for joining us. I'm going to close off the online segment. We'll have a quick touch point with the folks that are here in the room today. But to those joining us online, thank you very much for joining us. Slides should be up already if you want them, and the recording should be available within a few days. So thank you for your time, and you know how to contact us. Any policy questions, please direct them to your contact at the ministry, and if you don't have one yet, you can use the general Ontario Health Team's email address.